All right. Good morning, everyone, and welcome to the first of two Lunch and Learns that we have scheduled. Today, we are going to be talking with Asbel about the Medical Assistance Bridge Program, or it's also known as the MA Match Program, or GEMT. So if you have any questions, go ahead and put them in the chat box, or you can ask them afterwards. We are recording so that we can share this with other members who are not able to join us. I do have quite a few more who have registered, so they may pop in as we continue. If you have any feedback on these Lunch and Learns, if you want to see more, if there's subjects that interest you, it would be great to have that feedback. So today we have Asbel with us, and Asbel is a managing partner with Solutions Group Consulting. He began his career in the ambulance industry in 1999, and his career includes directing and leading teams that provide revenue cycle consultation to air and ground ambulance agencies. He has been a member of numerous organizations, including the Healthcare Financial Managers Association, the American Ambulance Association, the National EMS Managers Association. He is very involved at the national level, and he's on the board of directors for the American Ambulance Association, which is great. He is a respected thought leader on reimbursement initiatives within the industry and is a requested speaker at many healthcare conferences, including ours. So who is Solutions Group? They were created around a simple idea to empower EMS providers to collect their charges from payers and not the patient. They strive each day to innovate new solutions to meet the vision and build their team with passion always in mind. So this is great information. If for all the members who were members during COVID, you will remember that I shared webinars from Solutions Group. Asbel was very forthcoming with information for everybody, which was great. And they shared a lot of information on COVID, HHS payments, and compliance. So I do thank you for that, Asbel. So I'm going to turn it over to you.
Absolutely. Thanks, Heather. And always great to be speaking to my colleagues in Pennsylvania as well. A lot I see on here and some of the names on here I recognize, and thanks for spending the time. Heather also had sent me a few questions that some of you had already were asking prior to this. So I may touch base a little bit on those questions as we go through, and I've simplified this presentation to be very succinct and just to give you kind of an overview and pathway so we can have a little more time for Q&A through the process. I know that you guys have just recently received an increase in Medicaid, I think up to 80% of the Medicare allowable. And so how does a bridge funding program or these Medicaid type programs, how does that intersect with an increase in your Medicaid fee structure as it more closely aligns with Medicare? So I'll kind of walk through just some of that, answer some of those questions through the process. And there were some questions regarding what we call this mitigation pool that I'll kind of walk you through. Also going to talk about some things that we're currently working with CMS on that have percolated because more and more of these programs in the ambulance space are starting to happen in numerous states. And so it's brought up some questions as well. And so there's some clarification stuff coming through, especially around the provider tax piece as we continue to navigate through some of this stuff. So it's all good stuff. What I really like to see as we work through this is that the ambulance industry is beginning to understand that there are so many other payment sources available to the community outside of just our fee-for-service program as we see it. So that is what I love. Hospitals have been doing this for years, nursing homes and other provider specialties. And so it's now caught up with the ambulance industry as we continue to elevate as well and innovate, which is what we love as well. So thank you, Heather, for that. And I will get through this, and hopefully I've condensed this down to about 15 to 20 minutes. So it gives us some time for some Q&A. And depending upon how many questions you have, you might even be able to eat your lunch without having to hear my voice as well. So just so you know, and Heather kind of talked through this, and this might be old hat to some of you. To some of you, this might be new information, but there's a lot of different nomenclature that is used when you're talking about these bridge funding programs. Some talk about the provider assessment component, which is a lot of what I'm going to talk about today, but there is the Certified Public Expenditure program, which is the cost reporting side of it, or the CPE side of it, which is almost synonymous with what the ambulance industry is calling the ground emergency medical transportation side, or the GEMT type program. That is a CPE program that is really geared towards systems that are public, or what I would say are a unit of government. So think if you're a governmental entity, or you are codified in your local ordinance as a governmental entity, then you would qualify for what we would call a Certified Public Expenditure CPE program, or what we're referring to in the ambulance industry as the GEMT program. There are some things that people call, and they loosely talk about the upper payment limit, or it's a UPL program. UPL, or upper payment limit, is really kind of a threshold that I'll talk you through. These are what we call supplemental programs, or bridge funding or Medicaid funding programs could be. So you might hear some of that nomenclature out here. We're all talking about the same thing. It's basically a program that allows for some gap funding to come to a state to help augment reimbursement to Medicaid providers. Literally, that is what this whole concept is about. And it is codified, and I'll go through in a federal statute that talks and kind of governs these programs as well. So I'm going to specifically focus a little bit on the provider assessment piece of it. Just as a matter of reference, cost reporting type programs are voluntary and have been around for years. And the ambulance industry has taken advantage of these for probably upwards of 15 plus years or more. And so they're in about 28 states now on the governmental side, where you have to do cost reports, and every year you send the cost report to Medicaid. Medicaid looks at the cost of your doing services for Medicare and Medicaid recipients, or dual eligible recipients, looks at your cost, looks at how much you got reimbursed, and then there's a gap in between that, and then they will fund that gap through what we call a CPE program. But private, if you're a private ambulance service, a nonprofit ambulance service, a volunteer nonprofit that may not be considered governmental, then the only avenue for you to get some type of additional funding is through what we call a provider assessment program. Some people call it a provider tax, or something like that. You've got all different names of it depending upon the politics of your state, but it technically is a tax. And this is actually codified in the Social Security Act under Section 1903, and it allows for 19 permissible tax or healthcare provider classes. Ambulance was added to this class back in 2004, maybe. No, I'm sorry. Yeah, 2004. Don't quote me on that exact date, but it's around that time. Ambulance services were added into that. There was a subsequent reason why it was added in. And then I'll kind of give you some of that as it deals with the emergency medical service provider. But basically what this does, it allows, if the state codifies and takes this through a legislative vehicle to allow for the tax, it basically then allows that to be a permissible source for a state share match. So technically, in order for the feds to match state funds, it has to be through some type of taxing or governing entity. So either a legislative body, that's usually how most Medicaid programs are funded, is through a legislative, like it's a line item in the budget. They take that budget number and it draws down a match. Or any other taxing entity like the Certified Public Expenditure. If you're a unit of government, then that means that you are you are a permissible source. This allows for privates to be a permissible source, or whatever funding that they give through this tax assessment could be a permissible funding source. I won't belabor the point here. This is just to let you know that these have been around for years. And as you can see in the state of Pennsylvania, you currently have more than 3 of the provider specialties that are already being taxed. So it's not something new. As anecdotal to you guys, The company that we actually work with to do these programs, called Sellers Dorsey, actually is contracted with the state of Pennsylvania to manage all of your Medicaid funding type programs as it is. So that's an interesting tidbit of information. They're very aware. They're very aware of these programs. They help the state, and they've been contracted with the state for years to do that type of assistance with these type of programs. Currently, there are about 11 states, and there are several others that are already starting to consider this, but these are 11 states that have either passed legislation, in the middle of passing legislation, are working with CMS on it, that are actually doing some type of ambulance provider assessment currently. So it's already starting to gain traction through the process, and many states are starting to look at this as another way to help augment their fee structure. The public health emergency coming in has actually made a lot of states very flush with cash. And so a lot of you are beginning to see just a rate increase right now. So for instance, the state of Wisconsin started this program, and then, and I don't have them on the list for some reason, they're number 12. But the state of Wisconsin had started this program about a year and a half ago, and the legislator decided at that point to just increase their rates temporarily for at least a year or two. But they're also working, and just passed, to do the provider assessment as well, to help augment and get those rates higher. So if the fee structure goes away when there's no more money in the budget, this will allow this to continue through the process of them to maintain rates as well. So there's just different ways of doing certain things and using all the resources and tools that you have available to you. So let me kind of walk through just really simply for you on what this is. And if you're not really sure, this is a very good diagram on how the funding actually works and how the money actually comes back to providers. So of course, in a provider assessment, you would be paying off of a formulary a tax of your overall revenues that you provide to your state. So it'd be like a tax bill that you would get, and then it would be based upon whatever is the agreed upon tax rate, not to exceed 6%. So it could be anywhere from 0.5% to 6%. It would be, that would all be worked out in a modeling on what would be most advantageous to the EMS providers, to make sure you're not overtaxing yourself, and that you're also maximizing the drawdown that you can get for disbursement. But that you would be taxed, you would pay that tax like you would pay any other tax bill to the Medicaid agency. The Medicaid agency would take those funds, send them to the feds, bring down the match. Now, it would be distributed in two different ways. If you have Medicaid managed care, then it would be through a different funding flow that would go directly to the managed care, and the managed care to you. And that would all be tied up through contractual agreements on how that money gets back to providers. Or if it's just fee for service in the fee for service space, then it just goes directly to you in the form of a supplemental payment. And those are usually done on a quarterly basis or every 6 months. That's just dependent upon what is worked out with your state agency on how they want to pay those funds. They typically do pay those on a quarterly basis in your other provider specialties. So we would expect that if you did something like that in Pennsylvania, it would follow that same general rule. It wouldn't be a part of a direct payment as a fee for service increase. That's not typically how it works. You could structure it that way if you want to, but it typically just it's dispersed in a total overall supplemental payment that you just get into your account once a quarter for all the transports that you did in that preceding month and that preceding quarter. So what are the mechanics of this? And this is where I'm going to spend a little time, because some of you may have been talking to some of your colleagues in other states, and there is some discussion being had right now as we're continuing to work. And this is what I kind of alluded to, that Sellers Dorsey, we've got a huge team employed right now because of that the healthcare provider, when they actually implemented this for ambulance, it was defined as emergency service ambulance providers. Now, it wasn't defined on what was an emergency service ambulance provider. And so some are taking this that the only services that you can tax are emergency ambulance services and not the class of services, which if you're an emergency ambulance service, you might also do non-emergency services with that same emergency service ambulance. And so that is kind of where the discussion is. Can you tax both emergency and non-emergency services to do the drawdown? Now, you can pay out of the disbursement to emergency, non-emergency, but can you tax that? That is a question that is percolating now. And CMS is actually working on some clarification documents to states relative to this issue. And so, of course, there's a lot of work happening behind the scenes with states such as Massachusetts, Louisiana, that have been doing and taxing emergency, non-emergency for a while now. And so those are some discussions that are happening through that as we work through that process. So we're hoping that there'll be some clarification over the next 3 to 4 weeks as we work through this class, but it looks like they are going to be leaning more towards how it's defined at the state level. So for instance, if your state defines emergency service ambulance providers as only those that provide 911 services, in a whatever, that could be the governing definition that you can only tax emergency ambulance services. So the definition is going to be really imperative on state levels. What is defined as an emergency service ambulance provider? And so those are a lot of things that when you're working with a group is understanding that definitions have meaning. And they mean something on either the federal level or the state. And then you kind of have to work through that process on when you make that definition, what does it do on the state level and things like that. But I'm spending a little more time on this because I do know that that is some of the questions happening. And this is currently an active engagement that we are having right now with the Centers for Medicare and Medicaid Services as we work through this and with different states. As we noodle through this emergency service ambulance provider. So when this was done back in 1994 of the inclusion of this, there was a whole final rule that was done on this with the questions or what have you that came through this. So the intent was that emergency service ambulance providers was a class and not necessarily the service. And that is what we're talking through. So I'm not going to belabor the point too much on that. You might have some questions on that, and I'll get to those questions at the very end. I see things are happening. There's some questions starting to pop up in the chat. So what does a provider assessment and the mechanics of it? What does that actually mean if we were going to do that? Number one, it has to be very broad-based across the board. So it means if you are a private ambulance service or a nonprofit or a non-governmental entity, it would have to be levied on everybody. It is a mandatory tax. It is not something that's volunteer like the GEMT program. The GEMT program is a volunteer program. You can either do it or you don't have to do it. But on a provider assessment, it is a mandatory tax because it has to be broad-based and levied on all members of the class as defined and codified in your state law. It has to also be uniformed. So it means that you would have to levy the same rate on all assessed units. So if you decide on a 1% tax on everybody, it has to be 1% on everybody. It can't be 0.25 for this provider and 1% for the other provider. It also cannot have any hold harmless agreements codified into statute or codified in the state planned amendment that is issued to CMS. Basically says it cannot guarantee that your assessment that you pay, that you'll be made whole on the distribution that comes back. And I'll talk through some other questions that people have about a mitigation pool and what does that mean? And does a mitigation pool violate the no hold harmless agreements? And so I'll walk you through some of that. And then it talks about waivers. The broad-based requirement can be waived by the federal government in very certain exceptions. And if you do the waiver, it then has to go through this formulary that they call a P1, P2 statistical formulary that basically it would take the group that you want to waive and make sure that from a statistical standpoint that it's drawing down enough money to bring that back. So there are some waivers that are allowed. Typically, if you do that, it's in very, very, very rural areas that may not be able to do that. And you could actually work on like a rural or super rural waiver to exempt certain providers that might be volunteer rural ambulance providers. And we want to carve them out of this concept. You could do that, but it would have to go through this, what we call P1, P2 waiver. And then the thing that I mentioned earlier, guys, it is a maximum rate assessment of 6%. Some of you may have seen out there floating this 5.5%. That was a proposed rule that was rescinded under the Obama administration. So that was never changed. And so the maximum rate that you can assess right now is still 6% of what we would call the net patient revenue. And your net patient revenue formulary can be anything you want it to be, except it has to include your commercial, at a minimum, your commercial and private pay or self-pay accounts. You can exclude out Medicare and Medicaid and governmental payers, but at a minimum, you would have to assess the commercial revenue and self. This is just a case point, but this is a case study of what we've been doing in Louisiana on this piece of it. We could do case studies from others, but it just kind of walks you through some different providers and what they pay and the payment that they get back. Just note, based upon this, like small EMS provider A is a provider that does less than 10,000 transports a year. B does about 25,000 transports a year, and so does C. D does more than 50,000 transports a year. What makes the difference in the payment that you get back from your assessment is how much Medicaid you do, okay? So the more Medicaid you do, the more you will get back. The less Medicaid you do, the less you will get back, because that is how they correlate, because remember, they are Medicaid bridge funding programs. So it's really based upon the amount of Medicaid lives that you actually see, or that you actually transport as well. So the one that the median provider C that basically was underwater, 43,000, they actually paid more out in tax and they received, had a very low Medicaid percentage, but that was their business model of what they did. They didn't service communities that were underserved as well. So they had a very low Medicaid population that they saw as well. So remember, that is kind of what the differentiation is between who gets more and who gets less, is really based upon the amount of Medicaid patients that you would actually see through the process. A few things that you should consider through this process is, will states ask for a gain sharing of the amount that draws back? So if it's determined that the Pennsylvania program is a $20 million program a year, how much of that would the states ask for, or what they might see? What we are seeing in so far the 12 states that have passed some legislation is the states are asking for nothing or very little. I think one state's asking for like $50,000 a year to pay for someone to help part-time to help administer the program through the process. Typically, we do not see them asking for this, not meaning that they won't. But it is not something, because of the dollar amount. If they were asking for 10%, it's not a huge amount of money to their overall state budget. We typically are just seeing them for those that need it to cover the administrative fee of it. If we are seeing that in, if it's Medicaid managed care, that the Medicaid managed care entities are asking for 2.5%. To help with their administrative burden or whatever, which we kind of find ironic through the process. But if it's Medicaid managed care, typically what we're seeing is they're asking for about 2.5%. But for most states, they're not really asking for anything. There was one state that did ask for about $50,000. Also, there's a lot of things that's saying, well, how can we make sure that, okay, they pass it now, but how can we guard against the state legislator? That is all a part of the way that you craft your legislation. And that is something that any entity, I would strongly suggest that you contract with a group to help you. Of course, it's something that we do, but there are a few others that do some things as well. But that your legislation is going to be key, that you craft that before they can do something like that. It does require like a 2/3 vote of whatever your joint budget process is, or it requires it to go back for legislation. Some have mitigated that by requiring it to be looked at every 2 years, so that the state legislature can't come in and do that. So there's just different ways to do that based upon the politics in the state. And then also, The other question that we get a lot on is how can the EMS mitigate providers who pay more tax of a benefit than receive? And that moves into the next slide. And this is where there's been a lot of discussion in the industry. There was a lot of discussion outside of in other hospital industries and skilled nursing facilities. Many of you may have heard about the Medicaid financing rule, or what we call the MFAR rule, that was issued under the Trump administration and then subsequently withdrawn, that talked about these certain mitigation pools. The one thing that we talk about is, of course, that you can't hold providers harmless. So you can't put anything codified in state statute. You can't do anything under a state plan amendment that the state of Pennsylvania would send to CMS. But providers could voluntarily get together and say, you know what, we want to help and make sure that our peers don't try to mitigate something or go to a legislature to kill the deal because they might be underwater, and voluntarily put together a nonprofit organization that people can join that would have a benefit, and one of their benefits would be to assist in ensuring that this does not happen. I mean, it's voluntary, wouldn't be mandatory or anything. And those are the ways that, and we call those kind of mitigation pools. And we strongly suggest that you consider that and look at that. But it is a voluntary thing. You can't make it mandatory to participate in the program because, of course, you can't hold, there is no hold harmless provisions through that process. And so we call it a mitigation pool. Others call it something else. But it would be a voluntary thing. A lot of times associations will do that through an association as part of a member benefit or something like that, that would assist those that are part of this. And you would just bring a group together. And basically what would happen is those that are getting a large amount of money might pay larger dues than others that don't, to help pay and mitigate that loss that they might be experiencing. So the other thing is, well, if we decided to do this, how long would it take us? We typically say about 2 years. We are seeing some of this happen within 18 months now. It does appear that because in ambulance, they're approving these much quicker. For instance, the Oklahoma one was approved. It went from start to finish in less than a year. And they just actually got their approval about 2 weeks ago. From CMS. So that is probably the fastest that we have seen one. And we're starting to see it move much quicker under this administration, which is very interesting. But it's also, they have noted that this is helping to provide additional funding in the underserved communities, in the rural communities, to provide some sustainability funding as well. So we are chalking that up to that appears to be why they're sending some of this through the process much faster. So the latest approval from time of legislation to time of state plan amendment submittal to time of approval was about almost right a little over a year. So it's very interesting how quickly these are. The Massachusetts took about 18 months. In Louisiana, it took us about 2.5 years, but it was a new thing. So there's a lot of going back and forth with CMS through this process. As we implemented it, but we are seeing it move much quicker now. But that's kind of what you would be looking at, the timeline part of that. Here's contact information, and I'm hoping, Heather, that I simplified this for the group as well, but I do see there's some chats coming through as well, so.
Yes, thank you very much. It's a complicated subject, and that's the reason why we're having so many options for providers to ask questions. And one of the things, if we have to introduce legislation, it's going to take us a while. And with this being an election year, and then the new legislative session starts in January, that's kind of the time to start laying the groundwork for this. So the first question is the tax assessed on all transports or just Medicaid related transports?
So the tax is actually on all transport, so it has to be broad-based. So as a minimum, and this would be some modeling that is done. So as I indicated earlier, you can only tax up to 6% of your net patient revenue. So at a minimum, the definition for net patient revenue has to include your commercial and private pay. There is an option if you want to include your Medicare and Medicaid revenues. But at a minimum, it has to be your commercial and patient pay. But there would be modeling to figure out how much should you include. We'll know how much money you can gen up. And so then it goes through some modeling of the providers and then tells you, okay, you need to max out your 6% or you need to do 3.2% or 3.5%. But it is basically at a minimum your commercial and your private pay or self-pay.
Great, thank you. So how much is the fee or the tax that is assessed for the mitigation pool? And is there a formula that other states have developed? Because as we're talking the potential for up to 6% on the tax for the claims, but then you also have a mitigation pool, how much are we talking?
So I will tell you that typically when you're talking about, so the 6% is a little different than the money that's ginned up to either, if you've got to put stuff into the mitigation pool, what you usually do is assess and understand that. In some states, it's upwards of about 20% that they're looking by the time you pay for consultants and fees. In other states, it's higher than that. In some, they rebate money back. That really all depends upon how you want to build your program here in Pennsylvania. Or in some states, they've elected to pay for it out of pocket, hire the attorneys or whatever to do that, work through that piece of it. But there's different models out there. There's some that's a contingency model that you're paying someone to help deliver this to you. If it happens, they get paid based upon the net, or the net that comes back is a part of that. And then on top of that, that's where I'm talking about. It could be a contingency fee, or it might be just you quote it out there. And you guys pay for that up front, and it could be 50, 100, 150, 200,000 or whatever it is to work through. So I would recommend maybe an RFP process that you put out there, because there's several, and figure out which works for you as providers.
Great, thank you. Have you heard from other states that their Department of Human Services or their medical assistance program pushes back on this type of program?
Well, it all depends on, so it's all going to depend upon your state and those that want to do it or not. I typically will tell you that in more Republican states, they don't like the tax concept, and it's purely a political thing. However, as I've told you, in most of the states, when you saw that one slide, every state does have a tax. In Pennsylvania, though, do remember, and that's kind of why I led off, the group that I work with called Sellers Dorsey, they are actually contracted with the state, and these are the type of programs that they do. So I can tell you, in the state of Pennsylvania, they should not push back with you on this type of program at all.
Maybe, maybe not.
Maybe not, Heather.
Only because we've talked to them about trying to get an increase and everything, and we had to go the legislative route because they did not want to. They said they weren't going to file a state plan amendment. We found that they did, so we have gotten some pushback from them. So I know that that could.
Well, I will tell you this: this will require legislation. The state cannot do this without legislative approval.
And that leads us into the next question. When is this going to be available in Pennsylvania, and how do you go about getting in the program?
Yeah, so technically, in order to do a provider assessment program, it has to be legislatively driven to give authority to the state to even be able to do the state plan amendment. It works different than a GMT program. Typically, GMT programs or cost reporting programs do not need a legislative initiative. The only time that you ever see that being done is because the administration didn't want to do it, and so the legislature forced them to do it. But on a provider assessment program, even if the state wanted to do it, or your Department of Public Health or whatever you call them, I'm sorry, I should know that nomenclature,
No,
but I
that's
don't,
okay.
Heather.
That's all right.
But that even if they wanted to do it, they couldn't do it without legislative approval.
Right. And we're in a situation now where it is the election year, and not a whole lot is going to happen between now and the end of the year. There's some pieces of legislation that have to be passed, but we lost people in leadership. They did not win the primaries, and there's a lot who are not running for re-election. So it's a sine die session. So at the end of December, everything dies and you got to start all over again in January. So if that is something that the state is interested in, then we have some work to do.
Correct. And you would be correct. You would not do this type of program in a political environment like that.
Yeah. Yeah, you know, we just did a session yesterday for the EMS Leadership Academy talking about how we have to start all over again with education every 2 years. It's like that everywhere.
It's like the federal government, right? It's
Yeah.
everywhere. It's like it's everywhere.
Exactly. Exactly.
Everywhere. God love it. It makes our lives harder.
Some days, yes. So I think that pretty much covers all of the questions. The last one was, with that being said, basically this is not available in PA, but maybe in the future. And that is a yes, it may be available in the future. And we have a lot of work to do. We have to get the buy-in of the majority of the ambulance services in the state. And it's going to require some legislative, more calls to action than we've done in the last year.
That would be correct. And the only other thing is, I think there was a question, and I alluded to it, that you had sent me earlier, Heather, and that was about the 80% of Medicare that you guys currently were able to successfully get done in Pennsylvania.
Right.
And so currently you can go up to the Medicare fee schedule, or what we typically say is the best practice to do is to go to what we call the average commercial rate. And that average commercial rate can be defined several different ways. Can be defined as an aggregate of what the average commercial carrier is paying you in general. They usually take the top 3 to 5 payers and how they're paying you. So if they're paying you $120 of Medicare or $125 of Medicare on average, then that would be your ceiling. And so the difference that you would have available to you would be between the 80% that you're getting now of Medicare to that 125 of Medicare. So that gap would be what would be available to you in the industry as an increase through a program like this, if that helps and makes sense.
It does. Thank you very much. So do we have any other questions? Nope. Going once, going twice. Well, Asbel, I want to thank you very much for taking the time and providing this information for all of us. It's one of those things that it's complicated, and the more I listen to it, the more questions I have, and I'm sure I'm not alone in that. So if anybody has any feedback, please feel free to share that. And if you are interested in the Lunch and Learn session, it is next Thursday from 12 to 2. And it is on the Medicare data collection system. So we've got Scott Moore and some other representatives from the AAA that are going to be providing that session. And Asbel, I do thank you very much. I greatly appreciate your time and helping to educate us on this.
You're so welcome. Y'all have a good weekend.
Thank you. You as well.
Bye-bye.
Bye.